Hello, wonderful students. Myself, Dr. Maddineni Srinivas, your dermatology faculty from Bharat. So, watch this video till the end to quickly revise, recap the entire vesiculobullous disorder topic, important from exam point of view. Let us begin our discussion with the intra-epidermal blistering disorder, which is Pemphigus vulgaris, which is the most common type of the Pemphigus, and it is basically an autoimmune disorder which is going to have the antibodies against desmoglein 3 and desmoglein 1. Desmoglein 3 is more important, and it could also be due to the drug which is most commonly penicillamine. Clinically, we are going to see that the patients are going to have flaccid bullae, and there's going to be acantholysis happening where there is going to be suppression of the keratinocytes. So because of which we are going to see that the skin will be easily peeled off, that is Nichols-Kay sign is going to be positive. And remember, desmoglein 3 is present in the mucosa, so oral mucosal involvement, erosions, ulcerations are going to be seen. And if you take a biopsy, we are going to see that the basal cells are still attached to the underlying dermaepidermal junction because they are connected with the help of hemidesmosomes, which are absolutely normal and intact. So that is the reason why we're going to get an appearance which is called as row of tombstone appearance, very important, seen in Pemphigus vulgaris. So like I have told you, on Zaxmer we're going to see the acantholytic cells, which are nothing but the keratinocytes, which are the epidermal cells, and they are going to be rounded cells having hyperchromatic nucleus and a perinuclear halo. If you do the investigation of the choice, that is direct immunofluorescence, we are going to see fishnet or chicken wire pattern due to the deposition intercellularly of the IgG, or it could be also C3. Okay, histopath, very important, supra-basal split is going to be seen associated with the acantholysis. Coming to the treatment part, remember the first line treatment is going to be systemic corticosteroids. This condition is a very, very serious condition which is life-threatening, and the treatment should be very aggressive. There is a monoclonal antibody which is going to be targeting the CD20, and this is rituximab, which is FDA approved for the moderate to severe type of the Pemphigus vulgaris, and azathioprine and cyclophosphamide are the other ones which could be acting as a steroid sparing agents. Even pulse therapy, which is giving suprapharmacological doses of the medications, can also be used in this condition. Next is Pemphigus foliaceus, which is a variant of the Pemphigus. Here remember, the autoantibodies are present only against desmoglein 1. So the mucosa is going to be absolutely normal in this condition, and there is an endemic form. Just remember the name, it is also called as Fogosellvagum. So clinically, if you see, remember, it will never involve the mucosa. Pemphigus foliaceus is never going to involve the mucosa, and we are going to see superficial blisters which are going to easily rupture. So seeing a patient with blisters is very difficult in Pemphigus foliaceus. What we are going to see is scaling and crusting and erosions. And remember, the negative bulla spread sign will be seen in this because it is not having any blisters. Basically, it will be scaly and crusted lesions which are seen. And there is a syndrome which is associated with Pemphigus foliaceus. It is called as senior Usher syndrome. Just remember, Pemphigus foliaceus associated with the butterfly malar rash, we call it a senior Usher syndrome. And if you perform a DIF, you are going to see the deposition of the IgG in the upper epidermis. And remember, the histopathology is going to show subcorneal split. Why? Because desmoglein 1 is present higher concentration in the superficial layers of the epidermis, and treatment is going to be with topical steroids, mild forms, systemic corticosteroids if it is a little bit aggressive form. Next is bullous pemphigoid. Remember, in this we are going to see subepidermal blisters, and so these blisters are going to be tense blisters, and the age group is going to be seen in the elderly age group. And the antibodies are against BP180 bullous pemphigoid antigen 2, BP230 bullous pemphigoid antigen 1. And there is not going to be any Nichols-Kay sign. The reason is because this is a subepidermal blistering disorder, so there will not be any acantholysis. Remember, Nichols-Kay sign can be seen in conditions where acantholysis is positive, and less mucosal involvement can be up 10 to 30%. Percentage is not very important. And remember, it is a subepidermal blistering disorder, so it is a non-acantholytic blistering disorder. Subepidermal non-acantholytic blistering disorder is bullous pemphigoid. If you perform a DIF, we are going to see that the deposition is going to be in a linear fashion, and the deposits are going to be IgG and C3 along the basement membrane zone or dermoepidermal junction. And if you do a salt split, we are going to see that the immunofluorescence is going to be on the roof. And of course, these are the antibodies, and it is a subepidermal blister. Obviously, it is bullous pemphigoid. So treatment is going to be topical steroids for localized condition and systemic if it is little bit aggressive. Next condition is a herpes gestationals, which is also called as pemphigoid gestational. So it is just a bullous pemphigoid which occurs in a pregnant woman. Okay, here you can remember there is going to be association of HLA, DR3, DR4, and there could be cross reaction between the placental tissue and the skin of the mother, because of which there are going to be blisters seen in the mother. Very important. What is the location? It is going to be peri-umbilical area. We are going to see grouped vesicles. Very important point. Autoantibodies against BPG2, that is BP180. And recurrence is very common in the later pregnancies, and risk of flare is seen with menstruation and the oral contraceptives after the delivery of the child. Clinically, like I have already told you, peri-umbilical area is the most common site, and there can be intensely itchy urticarial plaques present, and this could also progress to vesicles and big bullous lesions, and usually begins in the second and third trimesters, and it is going to spare the mucous membrane usually, and not a mandatory thing. Okay, and it shows highest rate of spontaneous remission among all the bullous disorders after the delivery of the child, because placenta will be gone, so there is not going to be any cross reaction between the placental tissue and the skin, so it is going to show high rate of remissions or spontaneous remissions, and it may also flare at the delivery time, and it can affect the 10 to 15% of the children, but usually it is going to be self-limiting because of the antibodies crossing the placenta and reaching the child. There can be blisters in the child also, and if you do a DIF, just like the bullous pemphigoid, linear C3 deposition can be there, and also IgG deposition at the basement membrane zone can be there, and salt split skin is going to show the same immunofluorescence of the roof pattern, and it is a subepidermal bulla with eosinophils can be seen. And treatment part, if it is a mild, topical steroids, and if it is a little bit severe, then we can use steroids safely in the pregnant woman, and if there is itching, antihistamines can be used. Okay, postpartum immunosuppressions may be required in few of the individuals. Okay, and the complications, remember, small risk of the premature delivery, and also small for gestational age babies. SGA can be a big headache if seen in the pregnant woman. Next is the dermatitis herpetiformis. It is associated with gluten sensitive enteropathy, very important celiac disease, and it is due to the involvement of the tissue transglutaminase 3. And genetic predisposition is also important question. HLA DQ2, DQ8 can be there associated, and it is going to present with grouped vesicles which are going to be very itchy, which are seen mainly over the extensor surfaces, and there is going to be symmetric distribution. And remember, this is going to respond to dapsone dramatically. So if the patient, we cannot perform a biopsy, at times we can give dapsone and see if the patient is getting the relief, and if the patient is getting relief, we can diagnose it as dermatitis herpetiformis. So giving dapsone to a suspected dermatitis herpetiformis patient, we call it as therapeutic test. And if you do a direct immunofluorescence, we are going to see that there is going to be IgG deposition in a granular form. IgG deposition in a granular form in the dermal papilla. Papillary tip micro abscesses can also be seen if you do a biopsy, and the cells are going to be neutrophils. Okay, neutrophils in the dermal papilla. Intestinal biopsy, of course, celiac disease, villus atrophy will be there, and the anti-tissue transglutaminase 3 antibodies and also endomysial antibodies can be seen. The drug of choice for the dermatitis herpetiformis is dapsone, but remember, the treatment of the choice and the definitive treatment is going to be gluten-free diet. Gluten-free diet, very important point. Next is linear IgA disease. Remember, student, this is an autoimmune condition, and in the children we call it as chronic bullous dermatosis of the childhood. It could be also drug induced, where vancomycin is a very important drug, and antibodies are seen against BP180, that is BPAG2, and also 120, BP120. So very characteristic clinical features, we are going to see periorifacial string of pearls or cluster of jewels or crown of jewels appearance will be seen, where the vesicles are going to be present, forming a rim around the annular lesions which are going to be seen, and children are more commonly affected. Mucosal involvement can be commonly seen. And investigations, if you perform direct immunofluorescence, we are going to see linear deposition of IgA. That is the reason why it is called as linear IgA disease, of course, along the basement membrane zone. Histopathology, subepidermal bulla, not a rocket science. Circulating IgE autoantibodies can be seen in indirect immunofluorescence. Indirect immunofluorescence. Treatment, dapsone is the first line treatment. Systemic steroids can also be used. Next is a Hailey-Hailey disease, Darius disease. Remember, both these are genetic conditions. In Hailey-Hailey disease, the mutation is going to be in the ATP2C1, and it is a autosomal dominant, and Darius disease is also autosomal dominant condition. And basically here the ATP dependent calcium pump which is present in the desmosomes is affected, because of which the cells are going to be separated. So there's going to be acantholysis seen in these patients. So positive Nikolsky sign is going to be seen. And it is also called as benign familial chronic pemphigus. And usually flexural areas are the ones which are going to be showing vegetative lesions. And in investigations, remember this is a genetic condition, no antibodies. So DIF will be negative. Very, very important. Very important. And histopathology is going to show dilapidated brick wall appearance. Okay. In the treatment part, remember we are going to mainly use the retinoids if the condition is severe. Next is keratosis follicularis. It is also genetic mutation ATP2A2, and it is a dominant, so everything is the same except for the clinical features. Here the patients of the Darius disease, they are going to mainly have greasy papules, greasy hyperkeratotic papules will be seen. Again the sites are going to be flexural areas, and also remember the seborrheic areas are mainly involved, and it is also going to show acantholysis, but dyskeratosis is very, very important more than acantholysis, and it is a genetic condition, negative DIF. Histopathology is going to show some characteristic findings which are called as core rons and core greens. Of course, the treatment is going to be with topical retinoids. Systemic retinoids also can be tried. Next is the epidermolysis bullosa category. So remember, we are going to have 4 diseases which will have this prefix epidermolysis bullosa. 3 of them are genetic, which are simplex junctional dystrophica, and the fourth one is acquisita. It is not a genetic condition. So this is a very basic thing which you need to know. So coming to the epidermolysis bullosa simplex, EBS. Remember here there's going to be a problem, genetic mutation with keratin 5, K5 and K14, which are present in the stratum basal layers. So if there is a problem here, then there's going to be intraepidermal separation and basal keratinocytes will be affected. Clinically, we are going to see that usually children are the ones who are going to be affected, and the hands and feet are going to have the lesions, and it will appear at the birth, mostly at the birth, and it is going to be aggravated by the holding the child due to the friction, and due to handling of the child by the mother for the feeding or bathing, whatever. This is going to be the important history which will be given in the question. And recurrent blistering can also be there. And skin biopsy, of course, intraepidermal blistering can be seen, and genetic mutation of K5 and K14, keratin 5 and keratin 14 are seen. Treatment is going to be mainly genetic counseling and also wound care, because wounds are going to be seen very commonly, erosions over the palms and the soles. Next is the epidermolysis bullosa junctional. This is also a mutation of the laminin, so genetic condition. Okay, separation is going to be at the lamina lucida level. So it is a subepidermal blistering disorder, and we are going to see widespread blisters over the body. And remember the dystrophic part. Next one, so here we are going to have mutations of the collagen 7. So it is even more deeper condition. So D for dystrophica, D for deeper. So here the separation is sublamina densa. So K5, K14, and next one was lamina lucida, and next is sublamina densa. I hope you remember the structure of the basement membrane zone. So sublamina densa, we are going to have the anchoring fibrils. And clinically, we are going to see there is a scarring which is seen over the body because it is deeper involvement. So even dermis is going to be affected. So there is going to be scarring, severe scarring, and the patients, the children, are going to have the hands which will look like the mitten. So mitten deformity is going to be seen, and of course collagen 7 mutations. And the treatment is going to be with gene therapy, genetic therapy. Next is epidermolysis bullosa acquisita. Remember acquisita, this is an acquired condition, so it is autoimmune disease. We are going to see the IgG auto antibodies against the type 7 collagen. So remember epidermolysis bullosa dystrophica, collagen 7, there was genetic mutation. Here they are going to be auto antibodies. Very important point to remember. Okay, and it develops in the adulthood. Okay, this one acquisita, A for acquisita, A for adulthood. Next is clinical features. Of course, tense blisters are going to be seen. It is a subepidermal blistering disorders, and scarring is also going to be seen. Mucosa can also be involved, and linear IgG deposition can be seen at the basement membrane zone, and there will be circulating type 7 collagen autoantibodies. And if you do a salt split skin, the floor is going to show the fluorescence. Okay, and of course ELISA is going to show the type 7 collagen and autoantibodies, and it is a subepidermal bullous disorder. Treatment is going to be with systemic corticosteroids. And I hope this video was helpful. If you are having any doubts, please do let me know in the comment section, and do subscribe to this YouTube channel, guys. All the very best for all your future endeavors. Happy learning. If you want to join the Telegram group, all the group links of the dermatology are there in the description. You can check them out. Happy learning. All the very best. Bye bye.